It's a pleasure to welcome Jean-Francois Dufour. Jean-Francois is Clinic Director and full professor at the University of Bern. If you look at his CV while he's walking to the podium, he studied mathematics at the University of Geneva, has trained with Wynne Arias at Tufts University in Boston, and Marshall Kaplan, the New England Medical Center. And he's going to talk today about transarterial chemoembolisation. What is the best protocol? Thank you, Jean-Francois.
Thank you, Guy, for this very nice introduction. I would like to congratulate the organizers for this really wonderful meeting, very stimulating. I will talk about transarterial chemoembolisation, what is the best protocol, and I will address at the end of the talk combinations. These are my disclosures, more than one, which is important. Actually, when you perform TACE, it's a little bit like cooking a pizza. You have many ways to do this to achieve a good result. For a pizza, you need fire, you need dough, you need some cheese and tomato, and then fantasy cooking. You can put salami, you can put mushrooms, peppers, olives, herbs, and you have a wonderful pizza. Now for TACE, of course, there is the liver, there's a tumor, there's the patient, and then the fantasy kick in. You may have some beads, different size. You may have some different embolization material, like PVA, that's gel foam. Then you can add drugs, doxorubicin, epirubicin, cisplatin. You mix all that, and you have a nice TACE. Well, we'll go through that a little bit. But I think that TACE actually established itself because it is a very attractive test, very attractive treatment from the perspective of the patients. And this is what is important. For the patients, you don't have so much change of the quality of life if you undergo TACE. You go to the hospital for 1 or 2 nights. You can even have it on an outpatient basis. It's well tolerated. You have rarely complications. It's not a very fancy treatment. You don't have to travel 200 kilometers to do in a special center. It's relatively cheap, which is important nowadays. It can be repeated, as we will discuss. And it can be integrated in a treatment strategy when you have sequentially other treatments. And it works, as long as you are selecting correctly the patients for TACE, which is key. There are 2 randomized clinical trials performed 13 years ago, which actually demonstrated an improvement of survival of the patients treated with TACE. This has been confirmed in 2 meta-analyses, but it is a palliative treatment. If you look at the survival curve coming from the Barcelona group, from 104 patients at 5 years, you still have 5 patients alive, which maybe have been curatively treated by TACE, but this is a minority of the patients. So in the selection of the treatment for TACE, this is the famous BCLC scheme endorsed by the ASLD, by the EASL. On the left, you have resection for stage 0, then you have the Milano criteria for stage A, and you go for transplantation. On the right, you have advanced HCC, and you go for systemic targeted therapy. And you have the BCLC-D in patients who have child C on ECOG 3, when best supportive care is what you have to do. And in the middle, you have this big heterogeneous mixed bag of patients who have this intermediary BCLC-B. This is part of the problem. It's that there are different kinds of patients, but here the recommendation is to perform TACE. Are we actually following these guidelines? We look at that in our cohort 2 years ago of patients treated in Bern, and we look here at the different BCLC stages and what were the treatment. Are we actually following the recommendation? For transplantation, no doubt. For patients with BCLC-D also. But if you see for the patients with BCLC-B, a minority of them actually were treated with TACE. Some of these patients were actually resected surgically. There is a small population of patients in BCLC-B who may profit from surgery. We perform a search. You will hear more about it from Professor Peck. And we also enroll patients in different combination therapies. If you look at the other side of the coins now, looking at the treatment according to the BCLC, you see here transplantation, we will follow the recommendation. But for the TACE, there are many patients who were not BCLC-B who were treated with TACE. Mostly patients BCLC-A on the waiting list will have the TACE as a bridge therapy to transplantation. So if you want to select the patient, I think it's important to put the limit and to say when we should not perform TACE, when it's useless. Patients with an ECOG performance status above 2, child above 7, extrahepatic metastasis. It makes no sense, you have a lesion outside the liver, why you want to treat the lesion in the liver. Portal vein thrombosis, because then you risk complications. If there is no arterial perfusion, clearly TACE will not help. And I think one important point which was neglected, which is already clearly stated in the 2 randomized controlled trials from 2002, is the size. The 5 centimeter limits. If you perform TACE in a lesion which is 7 or 10 centimeter, you will probably not change the natural history of the patient. Here you have to think of something else, like for example, CERT. Then you will discuss to retaste the patients. Then you have to go through the same list, not only focus on the radiological findings. And the group of Marcus Peck proposed also to look at specific items here, like an increase of AST, more than 25%, paraduration of the child, and no radiological response, then it's useless to perform a TACE. But this kind of score, which is very helpful, still need to be further validated. There are several specialties involved in performing TACE, and you want absolutely to avoid misunderstanding and miscommunication. We have weekly meetings in Bern where we discuss these patients before and after TACE. And in the room, you need to have the liver specialist, the hepatologist, the interventionalist who will perform the TACE, and in our case, angiologist, and also a dedicated diagnostic radiologist. It's very important because it's difficult sometimes to assess what has been achieved radiologically. So you can look at the lesion and see what happened according to the RECIST criteria when you look at the size of the lesion, independently what happened within the lesion. Or you can use the mRECIST criteria, modified RECIST criteria, or then you try to capture the effect of TACE on the viable tumor. So you will look at the perfused lesion and take into account that there will be necrosis in the lesion. It's more difficult, obviously. It's more difficult, but it's probably important. Here is a paper in press in hepatology, one center, more than 100 HCC. You see the response rate. If you take mRECIST, it's 41%. If you take RECIST criteria, it's 4%, tenfold difference, huge. The problem with mRECIST is not easy. It's not easy, and you have intra and inter-observer variability. This has been nicely shown here with the kappa statistic on the right, especially in heterogeneous lesion, poor. So we still need really here to educate the radiologists to get more familiar with the mRECIST. Let's discuss a little bit how TACE is working. This is an explantation of a liver of patients who has been transplanted who had TACE while on the waiting list. You see the beads in the vessels, and what you achieve with the treatment is a necrosis, is anoxia. That's actually the way TACE work. Now, stating things like that, it poses the question, how important is the chemotherapy? How important it is to add doxorubicin and cisplatin to this treatment. Way back in the 2 meta-analyses that I mentioned before, there was sensitivity analysis suggesting that the chemotherapy was actually important. And then there's a meta-analysis performed by the group of the late Andy Burrows looking at this. If you see here the survival outcome comparing conventional TACE with transarterial embolisation, no difference. Now, there are 2 randomized controlled trials which actually specifically look at that. There is one from the group of Tin Meyer in London, But they randomized patients to have treatment with cisplatin and schedule of TACE or to embolization alone. No differences in the progression-free survival and no differences at all on the overall survival. Now, regarding the DC beats, the group of Malagari did the same, the randomized controlled trial, looking at the recurrence rate locally. Yes, you control better the lesion if you add the chemotherapy. But in terms of survival, which is at the end, what is important for the patient, no difference. So there is no evidence currently suggesting that adding chemotherapy is adding anything to this treatment. Unfortunately, it has some limitations. And the limitation is that when you have a necrosis and anoxia, at the border of the lesion, you have hypoxia. And this is a massive stress for the cells. They want to survive. They fight to survive. So they stabilize hypoxia-inducible factor. They begin to have a whole program to survive and to secrete growth factor, to multiply and to also attract new vessels. So you have secretion of growth factors. And so you think that's exactly what is happening. This has been shown here, immunohistochemistry for Ki67. As closer you are from the lesion, you have cell proliferation, endothelial cells, but also tumor cells. And you can measure in the blood an increase in VEGF, and so you have here a systemic effect, which you want to avoid. If you want to avoid that, you say it's easy, then you combine TACE with a systemic targeted therapy, you will block the systemic effect. Very nice background to do that. The data are all negative. The SPACE trial, which specifically addressed this, 150 patients were randomized in an arm TACE with sorafenib, 150 patients with TACE alone and placebo. Very nice study, but if you look at the results, time to progression, 169 days, 166 days, clinically irrelevant. And overall survival, 554 days, 564 days, clinically irrelevant. The study is negative. This has been discussed many times. There are subgroup analyses, but at the end of the day, this is negative. If you look at the brivanib trial, which has been reported earlier in hepatology, it's also negative. This trial has been unfortunately stopped early because the two other phase 3 studies with brivanib were already negative. So there's only a third of the events which were necessary to really power the trial, but the trial with brivanib is also negative. So no evidence that combining with systemic targeted therapy is actually helpful. So what to do then? What about to place a needle in the lesion and to apply some heat? You will burn the lesion. So you can do that after the TACE, because then you close some vessels, you will lose less heat due to convection with the blood flow, and you will have a nice localized necrosis. Are there any evidence for this combination? Yes, there is. Heterogeneous data, but enough actually to have been reviewed in the meta-analysis, which is just published in Liver International. You see here TACE with radiofrequency ablation in comparison with TACE, the 1-year overall survival. Despite the fact that it's not always easy to understand exactly what has been done in these studies, there is a clear signal here suggesting that the 1-year overall survival is better if you combine than if you do TACE only. Now you can pose the reverse question, TACE with radiofrequency ablation in comparison with radiofrequency ablation. More studies, there are actually 3 studies are from the same group and probably include the same patients, but here also an advantage in terms of survival at 1 year for the patients receiving the combination therapy. Here there was enough data to do analysis by the tumor size. Again, the tumor size is important. Less than 3 centimeters, more than 5 centimeters, no differences. This is apparently in this 3 to 5 centimeter, that actually you may make a difference if you combine TACE with radiofrequency ablation. This leads me to my conclusions. Transarterial, in parentheses, chemoembolisation. It's a very important tool in the treatment of hepatocellular carcinoma. It is widely used. It actually has been established too fast, and so we are lacking good scientific evidence for important questions. But its efficacy can probably be improved by combining it judiciously with, and currently the evidence is more in favor of radiofrequency ablation than sorafenib. I would like to thank all my team in Bern. If you want to learn more about us, you have our homepage, swissliver.ch. Thank you for your attention. Happy to answer some questions. Thank you.
Thank you. Likewise, we thought we would take questions immediately after the speakers. Jean-Francois, to the extent that, sorry, mine's a brief one. To the extent that liver function also determines the outcome, both after resection and TACE, do you think in an era of cure for hepatitis C, we really have to relook at these trials? Once we're curing patients with cirrhotic HCC associated with hepatitis C, but we've cured the hepatitis C virus, and then we use a modality like TACE or TACE plus RFA, as you pointed out. Do you think the prognosis could be changed? You're improving liver function in some, and you're also reducing the oncogenic effects of the virus. We need to relook at this.
Certainly, I absolutely agree. You may change effectively. You can retest probably more and test more patients because they have a better liver function, but we need the data.
Stefan.
Sorafenib is not a terribly well-tolerated drug, so was really the design of the SPACE trial appropriate? Would you consider that it would be worthwhile to restart a similar trial, but just giving sorafenib only just peri-interventionally, just a day before the TACE and a couple of days thereafter, stopping again, having not the side effects? Would you consider this a worthwhile approach? And the second question that is just a speculation, what would you think is going to be the new role of the combination when you use immunotherapy, the PDA1 inhibition? You think that nivolumab and TACE could be an interesting combination, or is it theoretically excluding each other?
That's two very good questions. For the first one, I believe that it's unfortunate that this trial were negative, because there's a good rationale to do the combination. Some trials actually do not use a systemic targeted therapy at the time of TACE, thinking that you may have more complications, but there is no evidence of that. Now, as you know, in the SPACE trial, there was also questions about the retention of the patients in the trial. And some groups were probably less familiar with this combination, let the patient out of the trial. And in the centers where they retain the patients within the trial, is actually there's a signal that the combination might be helpful. So yes, I think there is a possibility, a missed opportunity here. We missed actually to have the data showing support for this combination. Now, regarding immunotherapy, it's a very important question. When you perform TACE, and even more when you perform radiofrequency ablation, you have an immune response. We did that actually in a rat model with 2 lesions, and we performed radiofrequency ablation in 1 lesion and see what happened in the second lesion. You have an effect on the second lesion because you have an immunological response. Actually, you elicit an immunological response when you perform radiofrequency ablation. So now if you add a drug like nivolumab in this situation, yes, you may have potentiation. This is an attractive idea also, but which needs to be very thoroughly explored.
George, one last brief question.
Jean-Francois, thank you very much for this thoughtful presentation. So it's interesting the combination of TACE with RF that may be superior than TACE alone. But do you have data supporting that it's superior than RF alone? Because maybe it's the RF that does all the work, and then, yeah.
Yes, actually, in the meta-analysis, there was the 2. They were comparing TACE RFR against TACE, and there was a positive signal, but they were also comparing TACE RFR against RFA alone, and there was a positive signal. So comparing both possibilities, yes, according to this meta-analysis, you may have a benefit.
Well, if there are no more questions, thank you again. And let's proceed to the last presentation of this session.